Bismillahirrahmanirrahim. Hello, everybody. Welcome again to Ziada Academy. I'm introducing today a new video when I decided to shift from phaco to small incision cataract surgery in this female patient who is 80 years old with right sulfic eye and dense, very dense brown cataract in her left eye. The previous surgery was phacoemulsification 6 years ago, but this eye with good cornea and with good endothelial count too, but the cataract was very dense, so I decided to start phacoemulsification in this case, but putting in my plan to shift if there is any problem or if there is any hazard from using high power to divide and to emulsify this very dense cataract. So the patient's benefit and the visual outcome is the most important issue. Don't pay any attention to being a phaco surgeon doing very hard cases you have done and you will do again and again, but please put in your consideration the patient's benefit from your surgery, not your ego. So when I decided I will let video to move, as you see, there is very hardly apparent red reflex, so I decided to start as a phaco case. Yeah, and I have done the capsulorhexis with this less shiny red reflex, but it was good and the complete capsulorhexis, and as I fashioned it to be a wide rhexis to help me in any situation. Then the hydrodissection. No need for the hydrodelineation. It's one mass. All the lens is one mass. So it's moving. Now I'm going to divide this rock. I started with sculpting. I'm usually starting with the chopping mode on infinity machine, but in this case, I started with the sculpting mode with 100 torsional power and added ultrasonic power of 25. But actually, as you're seeing now, I'm stuck in this groove. Very hardly the hand piece can bite this nucleus. I'm trying to get it and hold it to divide using my blunt tuber, but actually it's very hard mission. So as this photo, it means that this nucleus was a need for this driller, not just the phaco machine. So I decided to save the cornea, and at the same time I will do surgery for this patient, keeping the cornea and keeping this surgery sutureless to be satisfied as a surgeon and the patients as well. And at the same time, the cornea will, the incision will be away from the cornea to reduce the corneal post-operative astigmatism and get a good visual correction after this surgery. So I fashioned my incision 7 millimeter wide and 1.5 millimeter from the limbs, and there is no problem. There was no problem from the phaco incision, the corneal incision, which was done for the phaco probe. Yeah, I completed the scare tunnel, and then I'm going now to enter the cornea with this keratome. The pupil went to be constricted, but still having a good space to move this nucleus to deliver it up in the anterior chamber, as you see now. Yeah, it's very hard one. It's rocky cataract. While by sandwich technique with a visco above and below, I could deliver this rocky nucleus or this black cataract with ease and safety. And after the visco expression and the thorough washing of the anterior chamber, I could implant the PMMA IL in bag, as you see now. I put the first haptic down in the bag and rotating the other to lie down in the bag again. I'm correcting the position for the centralization. Then I will correct the shape and position of the. Here I found that there is a very small knuckle, a very small vitreous knuckle, but with no tear in the posterior capsule. So I thought about the prolapse from a zonular dialysis or weak zonules in this part. So I prefer to do anterior vitrectomy to be sure that there is no problem. There is no vitreous prolapse or any knuckle angulating the pupil and yielding traction on the macula. And finally, my case wasn't in peace as sutureless cataract surgery, and at the same time I saved this patient from the major complication which may happen from use of extra power. I will burn the corneal endothelium and I will lose the cornea, and this is a big problem. And at that time, the patient will not be thankful for you. He will blame you and say you are the surgeon and you have the decision and you are responsible for the decision. Secondly, the zonules was weak and the nucleus, the bag was moving. So if I completed the phaco steps, this big nucleus with this big zonules could drop down into the vitreous. So please keep your patient safe and keep your coronaries as well. Finally, I closed the conjunctival, the incised conjunctiva by injection of the dexamethasone decadron to inflate, to balloon it and inflate to cover the scleral mold. Let's go to the patients. We will stop share. And finally, I will share again my desktop to show you the pictures of this patient's eye 2 days, just 2 days after surgery. Look here at the line of the scleral incision. It's well covered with the conjunctiva and healed, coapted with no stitches at all. This patient was satisfied and happy with the vision and the quiet eye. Here the cornea is crystal clear. The pupil is very normal, and the IL is stable, and everything was okay. Thank you for watching, and hope it a beneficial video for all of you. Thank you very much.